Okay, well, so we're going to be talking about the mechanisms of action in Rhegmatogenous retinal detachment. Roxanne Hillier is my co-chair, and we see this esteemed panel who have published greatly on various topics that we're going to discuss today. So I'm just going to start by talking about what is integrity in reattachment. What are we referring to exactly? When we see a patient with a retinal detachment, superior with several breaks, there's many ways that we can fix this. We all know that all of these techniques work very well. And this patient was 3 months after a detachment fixed with vitrectomy. Visual acuity was 20/25, and we've told the patient they've done fabulous. But when we look at it in more detail, we see that the patient had severe anisoconia. Objects were much smaller. And we've had this historical focus on single operation reattachment. This is our only main goal. But we have to now start thinking about functional outcomes because that's what's most important for our patients and for us. So reattachment is really the basic requirement. Putting the paint on the wall or the wallpaper on the wall, that's the basic requirement. We need to think about the quality of the job we're doing, the integrity of the attachment, and then we can maximize functional outcomes. We talk about this wallpaper analogy, and we don't want to just put the wallpaper on as quickly as possible with one procedure. We want to do it well. We want to minimize stretching and folding. And that's really the underlying concept of what we're going to be talking about today. So I'm going to start by discussing the importance of outer retinal corrugations. When you look at the retina with imaging, you can see these undulations in the outer retina that are deep, and we can confirm this with swept source OCT and see these beautiful corrugations in the outer retina. These are related to subsequent outer retinal folds, and we're going to talk about this in a lot of detail today, so I'm not going to go into it a lot. But what we're going to talk about is the pathophysiology. If you understand corrugations, you're going to understand so much more about retinal detachment and its repair. So let's start by looking at cases where you don't get corrugations. So for example, you have a small detachment, localized, you don't get corrugations, even after an extended period of time. It doesn't involve the fovea. You never get corrugations in the fovea because the Mueller cell cone acts as a rigid scaffold there to prevent that. But you do get it in the parafovea and in the peripheral retina. What about chronic, shallow, subclinical detachments? We also don't see outer retinal corrugations in these cases because the fluid is different. Also, it takes time. So if you have a bullous extensive detachment, you won't get corrugations until after 2 days. And this is related to changes in the elasticity of the outer retina that happen over time. What if you have a bullous detachment that's exudative? You also will not get corrugations. Again, the nature of the fluid is very different. What about a patient who had pneumatic retinopexy with corrugations and we treat it? And we'll see that as soon as the bubble goes in and the fluid starts to resorb, these corrugations gradually improve and go away. And if you have residual fluid, you also will not get these outer retinal corrugations. So with our engineering colleagues, we determined that to get corrugations, you need a change in the ratio of the elasticity of the outer retina to the inner retina, such that there's a reduction in the outer retina. And so if we look at the pathophysiology of outer retinal corrugations, you can use this mnemonic, SLEPT. It's size-dependent, location, it's foveal sparing, it requires an acute exposure to liquefied vitreous, you need a loss of pump control, and it takes at least 2 days. So I'm going to show you this animation video that demonstrates how this is happening. You get a retinal break, subretinal fluid goes under the break and causes a hydration of the outer retina. This hydration leads to an expansion, a thickening and a lateral expansion. So now you have more tissue in the outer retina relative to the inner retina. This leads to compressive forces, and with that change in modulus of elasticity, you get these outer retinal corrugations. So this is very important, and we're going to talk more about it because the way that you attach the retina will impact the integrity of the attachment based on how you deal with this. So in conclusion, to get corrugations, you need RPE photoreceptor regulation. You need, these outer retinal corrugations can lead to outer retinal folds and poor integrity, and understanding outer retinal corrugations will really impact management. Thank you very much.
Only one part of the morphological changes that happen to the retina. And so last year we published a prospective study on 49 consecutive patients in which we described for the first time the sequential morphologic changes that happen to the outer retina. And we used posterior pole and ultra-wide field swab source OCT, and we assessed the retina along the direction of the RD progression from the peripheral break to its leading edge. And we found that there are 5 stages of retinal detachment. And so stage 1 is the separation of the retina from the RPE with no apparent changes to the photoreceptor layer, and it occurs at the edge of the detachment, followed immediately by stage 2, where there's a thickening of this bacillary layer. Then we progress to outer retinal corrugations, initially low frequency, low amplitude, progressing to high frequency, high amplitude. As time passes, these corrugations will lose definition in stage 4, and finally in stage 5, there's a patchy then complete loss of photoreceptor inner and outer segments. And here's an animation video showing all stages together. So again, we have stage 1 at the junction of the attached and detached retina, followed immediately by the thickening of the bacillary layer. Then we have mild undulations and high-frequency corrugations in stage 3. And as time passes, these corrugations will lose definition. And finally, in stage 5, we have that moth-eaten appearance of the outer retina with a bare external limiting membrane at the end. And so this year we decided to do a larger retrospective cohort study to assess the validity, the clinical validity of our staging system, and we included 351 consecutive patients. We used baseline swab source or spectral domain OCT. Visual acuity was obtained at presentation 3, 6, and 12 months, and we excluded visually significant cataracts. And now our main outcome was the association of the stages with 12-month visual acuity. And what we found was that increasing stage was significantly associated with a longer duration of vision loss, as well as with a worse baseline visual acuity. And now from our primary outcome, increasing stage was significantly associated with worse post-operative visual acuity at all time points, at 3, 6, and 12 months, even controlling for time to surgery, type of procedure, baseline visual acuity, and duration of symptoms, duration of vision loss. But we know that obviously detachments of several weeks can do worse, but what about acute detachments? So we tried to do a subset analysis only in acute detachments, meaning those that had loss of RPE control, as Dr. Mooney discussed, acute, extensive, and progressive RD. So we excluded subclinical, chronic, and slowly progressive detachments that had that flat configuration on imaging or had 4 or more weeks of vision loss. And what we found is that 12-month visual acuity is no different between early stages 1 and 2 when compared to stage 3A. However, visual at 12 months is significantly better in stages 1, 2, and 3A when compared to stage 3B, and also when we compared adjacent stages 3A and 3B. So this suggests that stage 3A to 3B might be a critical transition point where significant structural changes happen to the retina, leading to worse outcomes. So what I want you to remember from this presentation is that the morphologic changes of the retina can occur in 5 stages. An increasing stage is associated with a longer duration of vision loss and worse post-operative visual acuity. Therefore, urgent intervention in stages 1, 2, and 3A may be beneficial for our patients.